Hospitals is the first line because you reside there. And these are really for patients that have had surgery because they're susceptible. Anytime you have surgery, you are going to have some level of trauma. Your immune system is somewhat compromised, and so now you become susceptible to secondary infection. So there's a big concern there. The other concern on infectious disease, which we're really interested in seeing, is what they call frequent flyers. These are individual patients that from a nursing home are now transferred to an acute care hospital, either for pneumonia or complex wounds or some other condition. The concern there is that from a governmental standpoint, if it's a Medicare patient and the patient is transferred in, you have to know whether or not that patient has an infection at the time of admission. Because if the patient you don't know and then the patient is discharged and they're on antibiotics, it'll be classified as a nosocomial or a hospital-acquired infection, and it'll affect your reimbursement. Now you also have the complexity of, did the infection start in the nursing home or did the infection really start in the acute care hospital? Now you've got this going back and forth. What we provide is kind of a continuity of care, and that is you provide the service in the nursing home or you provide the service in the acute care hospital. Now all of a sudden you take the ambiguity away. What you can do now is just to focus in on, was the infection there at the time of transfer, or was the infection developed at the time of being in the acute care hospital? Now you eliminate that ambiguity and you eliminate the finger pointing going back and forth, and therefore neither institution gets hit from a reimbursement standpoint, because many of them, as you know, are based upon capitation. Their capitation rates. Very few now in the nursing homes, I think, that are on a per diem. So there are some per diems, which means you get paid every day the patient's in the hospital, but in many cases it's capitation. And so if they're capitated under a DRG, for instance, then there's a set amount of money. If that patient has a nosocomial infection, you could lose that reimbursement for that patient. So it's rather interesting to see how this whole thing evolves. We watch the CDC pretty carefully because, as you know, the CDC is for the general public health and really are involved with public health departments all across the country. We look at statistically what's happening, and I've got articles which I pull all the time. This one has happened to be from a prospective study on 8 community hospitals and Duke University Medical Center, big medical center. And its morbidity and mortality in patients hospitalized with invasive MRSA. I don't know if you know what MRSA is, but MRSA, which is methicillin-resistant Staphylococcus aureus infections. What was interesting is that patients with MRSA bacteremia, which is they have it in their bloodstream, but it's not causing sepsis or blood infection, it was about 564. What was interesting is 34% of those patients expired in the hospital. So they were classified as bacteremic. It looks like if they were bacteremic, they ended up becoming septic. What was interesting is 57% expired after 1 year of discharge. And then the survivors that were rehospitalized within 90 days of discharge was 36%. So I think what you can see is that there's a real concern about this population of infection, and that's just with MRSA. You can imagine what it's like in complex pneumonias or complex wounds. And now we're dealing with things like Clostridium difficile, which is a byproduct of overutilization of antibiotics, where you're left with this toxic organism. Or vancomycin-resistant enterococcus, which is now a problem as well, because it's highly drug resistant. And what we're seeing is the shift of drug resistance, genetic drug resistance within organisms, which is creating a real problem for hospitals, because that goes to the treatment side. And so we're seeing more genetic drug resistance on the antibiotics that are our first line of defense. Vancomycin, from a standpoint of Staphylococcus aureus, especially with MRSA, is still the real treatment of choice. But we're concerned, we've seen a couple of patients that really have VRSA, which is vancomycin-resistant Staph aureus. We don't want to ever see that, because vancomycin is the drug that we really go to when nothing else will work. So it's been interesting to watch. I think there's an evolution that's starting to take place. I think ultimately it could be a revolution, but right now it's evolving. And the evolving is hospitals are looking at the potential of getting hit with reimbursement. Patients are looking at having exposure now to very lethal organisms. Pharmaceuticals, the problem is the potential of having drug resistance. So what we have is this evolving area of infectious disease that even the government is concerned, what do we do, what alternatives are there? And I think one of the alternatives is to look at technology, definitive technology that can accurately diagnose and identify individual organisms. I don't think any longer we can screen. I think we have to be confirmation. We have to confirm, because if the physician has a screen, he's just going to treat based on those symptoms. If he's definitive, now he can target his therapy. Once that therapy is targeted, you're going to have a better patient outcome.